Rohit Saxena sir and Dr. Anita to take over from here for the squint neuroophthalmology session. Support team, please give the agenda and notepad here.
Good morning. It's wonderful to see you all on the early morning, and thank you for our judges to help us to be on time. We'll now start the session on strabismus and neuro-ophthalmology.
They are bringing this is the previous
phone pe hoga. So while we are getting the details of the current program, I'll just see if we can get it on our phone so that we can start. Yes, tell me. Very good. Going on, or so you want to start? Just give us a minute. Let's just get the list.
What's your name?
Sameer Chaudhary should be. नहीं ये वाला है नहीं. ये तुम्हारा दूसरा वाला है. ये afternoon वाला है. ये तुम्हारा afternoon वाला है. Yes, please. Thank you. I think we're done. Yeah. So, okay, Sameer, we'll probably start with you then. We have Dr. Sameer Chaudhary who will be presenting his case on sudden vision loss in a pineal gland tumor. We'll start with him as he has to go, and then we'll go back to the ordinary. Yes, Sameer. Just inform there so that they can put your presentation. Can we just check in the meantime, Dr. Anhita Shroff available?
Anahita Shroff.
Anhita Shroff?
Yedula Venkata. Shafra Subhani is here. Nikita Sharma. Ishani. यही पूछ लेते हैं कौन है?
Nishi Satish.
Nishi just told us.
Okay.
She is. Sameer Chaudhary.
Yeah,
is here.
Nishi will come a little later. Sameer is here, so I think you are anyway going to start. Sanjana Thomas. I think we'll finish the program very early. Keshav Kumar. Charu Mittal. Okay, Charu Mittal. Sure, so we know who's going next. You are on, Sameer, please.
Thank you, sir. A very good morning to one and all. I am Dr. Sameer Chaudhary, and I'll be presenting a very interesting case of sudden visual loss in pineal gland tumor, blindness due to the third eye. So pineal region tumors contribute to less than 1% of all primary CNS tumors, and the clinical manifestations resulting from them are mostly due to the anatomical relations. So the pineal gland is related anteriorly to the third ventricle and the aqueduct of Sylvius, and inferiorly it's related to the midbrain and the brainstem. So the clinical manifestations most commonly include the Parinot syndrome and the horizontal gaze palsies. It can also cause obstructive hydrocephalus and slowly progressive vision loss due to the obstruction of the aqueduct of Sylvius, resulting in the setting of disc edema. So in this, we report a case of sudden vision loss with pineal gland tumor associated with Parinot syndrome and 1.5 syndrome. So a 9-year-old boy presented to us with sudden onset painless defective vision for 1 week in both eyes with subacute progression. This was associated with vomiting and headache for 1 month along with an isolated episode of seizure 3 weeks ago. On examination, a visual acuity of nil light perception was revealed along with lid retraction suggestive of Collier's sign. The pupil was 5 mm dilated with sluggish reaction to light, and the extraocular movements were limited in abduction, elevation and adduction in right eye and elevation and adduction in the left eye. Both eyes revealed upbeating nystagmus with retraction of globe and convergence on attempted upgaze, as is depicted in this particular video, where we can see an convergence retraction nystagmus in upgaze with limitation of upward movements. So fundus examination was unremarkable, revealing a normal disc without any sign of pallor or edema. An MRI revealed an heterogeneously enhancing lobulated mass in the pineal region, along with obstructive hydrocephalus and dilated third and lateral ventricles. At this point, a diagnosis of optic neuropathy, Parinot syndrome and 1.5 syndrome was made, and patient was advised definitive neurosurgical management. So 5 days from presentation, the patient underwent VP shunting, and on the second visit, 10 days, the patient had temporal pallor, right horizontal gaze palsy, and although the visual acuity was nil light perception, very surprisingly, the patient was complaining flashes of light. 45 days, the patient's visual acuity recovered and was improving to hand movements and light perception. On visit 4, it further improved to half by 60 and finger counting close to face. And 4 months from his first visit, the patient underwent craniotomy and partial excision of the tumor. During his final visit, the patient's best corrected visual acuity was 1 by 60, partial Parinot syndrome persisted, there was diffuse chalky pallor, and patient was advised low vision aids. So what is unique in this particular case? Pineal gland tumors are not a known cause of sudden vision loss. The proposed mechanism of vision loss is a dilated and anteriorly displaced third ventricle due to the obstructive hydrocephalus, which causes the compression of the optic chiasma, which is very closely related to anteriorly to the third ventricle, invaginating into it at the optic recess. A similar mechanism has been reported in a case report prior to this. So the clinical implication, this report highlights a unique mechanism of vision loss in a setting of hydrocephalus and ventriculomegaly. Prompt measures such as VP shunting might preserve and improve vision. And pineal gland, the take-home message should be pineal gland tumors can be a rare cause of sudden vision loss. Ventriculomegaly with displacement of the third ventricle can cause compression of the optic chiasma and result in visual loss. Thank you.
Thank you, Sameer. That was a very interesting case. Picking up all the signs was very important, particularly, of course, there are multiple reasons why an imaging would have been done. What was the imaging that was advised? And
So MRI was done, sir, initially with contrast.
okay, any localization you were able to give in the beginning when you were advising the MRI?
So the patient was actually referred to us by a neurosurgeon, sir, initially, and by Parinot syndrome, like Parinot syndrome is localizing for pineal region tumor anyway. Initially, we were not able to know the loss of cause for the sudden vision loss, but after reviewing the literature, we came up that it could be possibly because of the compression of the optic chiasma due to the anterior displacement and dilatation of the third ventricle, because it resulted in improvement as well from NLP to 1 by 60 after VP shunting.
But the vision didn't recover significantly,
Not
considering
significant.
that it was
Yes,
a
sir.
fairly acute presentation, and one would not have expected such a severe vision loss to occur, in a permanent vision loss to occur. But anyway, yeah, there are many things we don't understand. I think, Sameer, that was a wonderful case. Thank
It
you.
was
Thank you,
all
thank you, sir.
wonderfully explained. Only as sir already said, the only thing was the history. It was very acute. So we expected it to be little chronic and the gradual.
Actually, the vision loss was over a 1 month, ma'am, and it worsened over like the last 1 week before, just before the presentation.
Thank you.
Thank you, ma'am. Thank you, sir.
Dr. Rohit Reddy.
Is there Anhita Shroff has come? Okay. Anhita Shroff. We'll take it after this. Okay. So you need to alternate. Just check if your presentation is there. You probably will be there next. No problem. That's okay with us.
Good morning.
Yeah, go ahead.
Good morning, everyone. I'm Dr. Y.V. Rohit Reddy. I'm going to present a case titled Bilateral Retrobulbar Neuritis with Anti-Jo1 Antibody Myositis as a manifestation of neurosarcoidosis. Retrobulbar neuritis presents as acute painless vision loss. Neurosarcoidosis is a rare inflammatory CNS disorder. Anti-Jo1 antibody myositis is commonly linked to inflammatory myopathies but rarely with neurosarcoidosis. This case uniquely presents bilateral retrobulbar neuritis with anti-Jo1 myositis, suggesting neurosarcoidosis as the underlying cause. Case details: 48-year-old female with progressive bilateral vision loss for 1 month. History shows she's hypertensive for 2 years and prior hospital admission for suspected proteinuria, and she was treated for 1.5 years. Systemic findings shows muscle tenderness, pulmonary involvement, and constitutional symptoms. Ocular examination, visual acuity, right eye 624 with no improvement, and RAPD was seen. Color vision was impaired and confrontation test restricted. Left eye visual acuity 66 and color vision normal, confrontation test normal. Anterior segment both eye within normal limits. Posterior segment fundus shows temporal disc pallor in both eyes and rest within normal limits. Coming to investigations, MRI brain and orbit was done. It showed bilateral optic nerve enhancement, and cerebrospinal fluid analysis showed elevated protein lymphocytic pleocytosis, and serology showed anti-Jo1 antibody positive. Pulmonary evaluation on chest X-ray, right-sided hilar opacities were seen. Muscle biopsy was done, features consistent with inflammatory myositis, and PET scan showed hypermetabolic lymph nodes suggestive of systemic sarcoidosis. MRI brain shows well-defined enhancing lesions at the right orbital apex and planum sphenoidal, cavernous sinus, left tentorium, temporal lobe cerebellum with minimal edema. Thick nodular meningeal enhancement was seen. Differential diagnosis could be tuberculosis, neurosarcoidosis, lymphomatous deposits. On HFA, both eyes showed central depression. Course of treatment, high dose IV corticosteroids were given, and oral steroid tapering and transition to methotrexate was done. At 3-month follow-up, regression of hilar lymph nodes and visual acuity right eye, it's improved to 6/9 with better visual fields. And patient on the course of treatment, patient developed left T10 to T12 herpes zoster. She responded to acyclovir. Multidisciplinary approach was done with neurologists, pulmonologists, and rheumatologists. Results and follow-up, significant visual recovery after steroid therapy, resolution of muscle weakness and systemic symptoms. A repeat MRI was done, it showed reduced optic nerve enhancement. Long-term monitoring was required to assess relapses and systemic involvement. Continued low-dose steroid and immunosuppressive therapy for prevention. At 10 months, these are the reports. Patient is doing well with improved visual acuity and fields, except for mild decreased color saturation. What is unique in this case? A rare association of anti-Jo1 myositis with bilateral retrobulbar neuritis. Neurosarcoidosis presenting without classical systemic sarcoidosis symptoms. Multi-system involvement requiring a multidisciplinary approach. Emphasizes the importance of early diagnosis and immunosuppressive therapy. Clinical implication.
Finish. Just complete this first.
High suspicion. High suspicion needed in atypical optic neuritis cases. Autoimmune markers can aid in early diagnosis. MRI and PET scan are crucial for systemic evaluation. Timely steroids and immunosuppressive therapy are critical for visual recovery. Take-home message is neurosarcoidosis can present as bilateral retrobulbar neuritis, and anti-Jo1 antibody myositis is a rare but possible association. Multimodal imaging and serology are key for the diagnosis. Early immunosuppression can prevent permanent vision loss.
Thank you. I'll ask Dr. Shailaja also to please come on the dais. A very interesting case. How did you confirm sarcoidosis?
After doing MRI, showed enhanced lesions. Then we confirmed the diagnosis with chest X-ray also showed right-sided hilar opacities, and then PET scan showed hypermetabolic lymph nodes.
Okay. Okay, sure.
Any specific test for sarcoidosis you have done? Any blood test?
All routine investigations were done. CSF analysis was done.
Okay. So other eye was, you have written the title
Bilateral.
bilateral. Other eye
Patient
was involved.
complained of both eye vision loss, ma'am, but on examination it was 6/6.
So have you done any conduction studies like visual evoked potential or something
No,
like that?
How could you say it was bilateral? Was there any other visual functional deficit that you could pick up?
There is mild visual field loss.
But then early visual, it could be a learning curve. Anything else? So you could look at color, contrast, nerve conduction. Before we label it as bilateral, you need to have evidence. The patient may just mention that that there is a little quality of vision which needs objective evaluation. But good. Thank you. Thank you. Very nice. Thank you very much.
Next is yes, Dr. Anahita Shroff.
Good morning. So all of us as ophthalmologists are trained to recognize bitemporal hemianopia in all pituitary tumors. But what if the fields are different? Today, me, Dr. Anahita Shroff, am going to take you on a junctional journey. So I'm going to present a case, a unique case of a pituitary tumor which presented with an atypical junctional scotoma. Our patient, a 64-year-old male, presented with painless gradual loss of vision in the right eye since 1 year. On examination, he had an early cataract in both the eyes with a grade 3 relative afferent pupillary defect and a pale disc in the right eye. There were no systemic indications or no trauma to suggest the pale disc. So we went ahead with the MRI. On the MRI, we saw an iso-intense lesion in the sella suprasellar region compressing the right optic nerve at the anterior junction of the chiasma. The same lesion can be seen in the T2 weighted coronal section and the T1 weighted sagittal section displayed here. The differential was consistent with pituitary adenoma. So obviously we were expecting pituitary is bitemporal hemianopia, but that was not the case. To our surprise, the fields in this patient were very different from what we had expected to see. There was generalized depression in the right eye and superiotemporal depressed points in the left eye. We referred the patient to the neurosurgeon, and after successful surgical excision, even though the pallor persisted, he improved symptomatically as evidenced by the improvement in HFA and the vision, and with his last visit to us, his vision was improving to 6.6. So what is the underlying secret in this case? It is the knee of von Willebrand. The inferonasal fibers of the contralateral eye loop at the affected optic nerve before crossing at the chiasma. So this is given by Dr. Willebrand, where you can see that these fibers loop around and then they are crossing at the chiasm. So any lesion that would compress this area would cause what we call a junctional scotoma, which involves superiotemporal defect in the contralateral eye and a central scotoma or a generalized depression of the compressed optic nerve of the affected eye. So the eye does not see what the mind does not know. We need to recognize the pattern and order urgent imaging and endocrine workup before vision loss becomes irreversible. The treatment for pituitary tumor is surgery, we all know that. But identifying junctional scotoma will help us localizing the lesion more accurately and help the neurosurgeon in planning adequate surgical debulking surgery, as well as we'll know what improvement in the vision to expect post the decompression. So all that glitters is not gold, and all pituitary tumors are not bitemporal defects. Know the anatomy or the diagnosis might fool you. It is important to correlate all the pituitary tumors, the imaging and the fields to come to an adequate conclusion and improve patient care. Thank you.
Thank you, Dr. Anahita. A very important point that you need to actually be aware of all the various positions the pituitary has in relationship with the chiasma, so that the variations in the field effects, and which can be many. So yes, it's an interesting thing to talk about. Of course, uh, these localizations were extremely important before we had very good investigative modalities, but still it's very important to be able to localize, because you need to direct the view of the radiologist as to where you want the lesion, where and what kind of lesion. And despite we think that all MRIs are the same, you will be uh, just kind of overtaken by the number of now changes and developments that have come in the MRI. So now you have to actually very specifically write the kind of imaging you want, or else localize the site and the tentative lesion that you are thinking, so that the appropriate investigation can be done. Shailaja, any comments?
I was just asking that was the fields done before the MRI or after the
No, ma'am,
MRI
we did
as it
the
is?
MRI first. Since there was pallor, we wanted to know if there's something going on inside.
So if you do the MRI first, then you lose the localizing capacity or the
Yes,
function of
ma'am.
the
We
visual
did the fields for
So
documentation. We were expecting a bitemporal, but it came out like this. So we thought it was something interesting that is worth.
yeah, but it could have been done the other way. That's usually the case because bilateral temporal pallus could be because of, in a
It was
patient could be
unilateral,
because of
ma'am,
any,
only
yeah,
right.
yeah, unilateral also it could be because of any other pathology other rather than an ICSOL. So whether to image for an ICSL or not depends upon the fields. So first you would do a fields, and you can do a fields with a 660 vision with a stimulus size 5, and get you could have got this information even before, and use it exactly as Dr. Rohit has mentioned.
Thank you. So, is Shafra Subhani is here? Shafra Subhani. Nikita Sharma. Ishani. Nishi Satish. She has went.
She's coming back.
Sameer Chowdhury. Sanjana Thomas.
Keshav Kumar, is he there? Keshav is there? Keshav, you can come up front. Oh. Sanjana is there? Sanjana is coming up? Yes, Sanjana, please. Keshav, you'll probably be on that side. Just wait, I just wanted. Actually, you have it
He's
here
here.
ready. Sanjana would be there. Sanjana is next first. I just wanted to know. Keshav, you can just sit up front. Sanjana, you can just take your presentation.
Keshav, you can.
Chalo, Keshav, you can start while Sanjana will have to just, I think they'll just check your presentation. Yes, Keshav, please go ahead.
Good morning everyone present here. I am presenting a case report of orbital lymphoma, masquerading orbital apex syndrome. Orbital lymphoma is an uncommon form of extranodal lymphoma. It presents as painless orbital mass with progressive proptosis and diplopia. It can mimic as orbital apex syndrome, which is characterized by optic nerve dysfunction and involvement of multiple cranial nerves. In this case, the initial presentation of vision loss, ophthalmoplegia and ptosis lead to diagnostic dilemma. On case detail, a 72-year diabetic male presented with complaint of pain and sudden loss of vision in left eye since 1 week and drooping of left upper eyelid since 1 week. There was no history of double vision, headache, vomiting, colored halos, fever, weight loss. Patient's routine blood investigation are within normal limit, and on local examination there was facial asymmetry present due to elevated left eyebrow and drooping of left upper eyelid. On ocular examination, visual acuity of left eye is PL and PR positive. On examination of eyelid, there is drooping of upper eyelid present in which levator function is poor or MRD is -2. For orbital examination, there is proptosis was seen and warm eye view of navicular test were positive, and there is no pulsation seen in retropulsion and no orbital bruton seen. Pupillary examination, pupil are dilated and non-reacting to light. Lens grading is nuclear sclerosis grade 2. On extraocular movement are restricted in all gaze, and there is slight decreased movement in left lateral gaze. Investigation include B scan, small bilobe cystic lesion of 15 into 5 mm noted at the apex of the left orbit. On MRI, there is lobulated T2 ISO2 hypointense mass lesion seen in orbital apex, measuring 1.7 to 0.7 centimeter. It is seen enhancing the optic nerve. Some other similar lesions seen along with the lateral rectus, inferior rectus in extranodal compartment. Another discrete nodule measuring about 1.9 into 2.1 centimeter is seen in the infratemporal fossa in intermuscular vein. Management include conservative management. Patient was initially managed conservatively and then referred to higher center. Unique thing is that there is a presentation with painful ophthalmoplegia and severe diminution of vision, while orbital lymphoma is a painless condition with progressive vision loss. In this case, the location of the mass is within the corneal space at orbital apex, while generally the orbital lymphoma is presented extracorneal space and involving the muscle first. Clinical implication include this case underscores the critical need of high index of suspicion when evaluating patient with orbital apex syndrome, especially with atypical presentation. Thorough clinical evaluation, imaging, multidisciplinary management can prevent vision loss and improve patient outcome. Take-home message was orbital lymphoma can mimic orbital apex syndrome, which lead to potential misdiagnosis and treatment delays. So every case need local as well as systemic examination. Early radio imaging can play crucial role in differentiation of the disease and help in initiation of the treatment. Thank you.
Thank you. So What could be the cause of pain in your case?
Due to compression, ma'am, there is mass present at apex. It may be compress the or eyeball or
So otherwise also lymphoma is compressed. So what was different in this case?
large growing tumor, large size tumor of 20 centimeter approx.
Shailaja?
I sorry if I missed. Was a biopsy done?
Ma'am, patient was referred higher center. A biopsy was done there.
So why are you saying it's lymphoma only based on MRI?
नहीं, ma'am, we consult patient and there they said there was मतलब वहाँ फोन करके पूछे थे मैम और लिम्फोमा बताया और उनको
So
रेडियो
after
कीमो
the biopsy, in retrospect, you came to know that's lymphoma. So what would be the differential diagnosis of a lesion which looks like this on an MRI?
मैम there is orbital apex syndrome.
So orbital apex syndrome again is it's like a clinical entity, right? What are the
So the
causes
cause
of
of an orbital apex.
syndrome?
Orbital apex is localizing to a region.
जी.
Okay, that's what. So when you have a plethora of certain set of signs like a syndrome is a group of signs that can identify, right? So orbital apex is that because of the signs that are present, we are able to localize it to the orbital apex. Now, multiple lesion, one of them is lymphoma, could be other tumors. So any secondaries or primary tumors. That could be any other thing that can present as an orbital apex.
Infective cause present and
So infections, inflammations, infections that can come from the paranasal sinuses because they are like just there. So those are areas where, and you can have other things also presenting anything that is there. Sometimes even thyroid can, if the muscles increase in size posteriorly. So multiple, any lesion at the orbital apex will present with an orbital apex syndrome. So then, as is being discussed, a biopsy or if possible are the ways in which we confirm the etiology and manage. Thank you. I think very nice presentation, a very, very important thing to remember. Again, in neuro-ophthalmology, it's key to be able to localize and appropriately advise. If in this patient you had just advised an MRI without any details, there, of course, this is a very large lesion, could not be missed, but sometimes subtle orbital apex syndromes can be missed if you just order an MRI. Again, back to, while it's theoretically seems that, just get an MRI done, why apply your mind, but often we have been misled by a previous imaging where this has been missed because the wrong investigation was done and you realize that it is not showing the area of interest and you have to go back and repeat the imaging. So the importance in neuro-ophthalmology. Sanjana, I think Sanjana is ready. It'll take some time. Charul Mittal, please.
Good morning, everyone. So I'm presenting a case here, similar like the previous one, an orbital apex syndrome and total ophthalmoplegia. So orbital apex syndrome is an uncommon disorder involving multiple cranial nerves, including the optic nerve. Patient presents with total ophthalmoplegia and visual dysfunction. The etiologies can be, as Sir said, inflammatory, infectious, neoplastic, traumatic, iatrogenic, vascular, etc. So my case was a 60 years old female, and she presented to us with a right eye total ophthalmoplegia. So she has a history of right upper jaw pain 4 months ago, and it was followed by 4 teeth extraction, that is the incisor, canine, and 2 premolars in the right upper jaw. It was followed by fever for 4 weeks, and it was managed conservatively. The ESR at that time was raised, but other markers were normal. The typhoid and malaria, the fever panel was within normal limits. And she is a known case of hypertension with poor compliance to treatment. On ocular examination, the patient had complete ptosis, loss of forehead wrinkles. We can see all the signs of facial palsy, and we can see in the 9-gaze picture that there is right eye total ophthalmoplegia. And the pupil was dilated and fixed. The vision was finger counting at 1 meter, and The lens had cataractus changes. The left eye was unremarkable. So here I wanted to examine the oral findings of the patient because she had a history of fever and she had a history of pain in the jaw. So I found that the local site was completely healthy and X-ray, she had the X-ray with her in records. So it did not show any local signs of infection. So here our suspicion was a skull-based infection that has penetrated deeper or a neoplasia. She had consulted multiple practitioners before and their suspicion was also the same. So we went for an endoscopy here, and the nasal endoscopy, and we found a globular round mass in the sphenoid sinus. We can see here, and we took a biopsy from it. So, and after finding a mass, we ordered a CT PNS, and we found a mass here involving the orbital apex that is extending into the right orbital apex and completely destroying the skull base and more towards the right side. And on biopsy, we found moderately differentiated squamous cell carcinoma. So, of all cancers, head and neck cancers comprise 26% in males and 8% females in India. So, orbital apex syndrome is itself a rare disorder, but only a few cases reported in association with head and neck cancers. So, unilateral orbital apex syndrome is secondary to skull base neoplasia, and the presentation here suggests that the tumor is locally aggressive. So, my take home message is that the history can be misleading. So, initially we were thinking in terms of infection, which was not there, and total ophthalmoplegia can be an ominous entity, so we need to have a high degree of suspicion. Thank you.
So,
Charul Mittal.
Charul
Skull-based
Mittal. Okay,
osteomyelitis
okay,
and
okay.
ophthalmoplegia.
Ma'am, the title here is wrong. I submitted
Yeah.
a different title. I mailed, but it wasn't correct.
Okay, okay, okay. So, you have referred the patient to ENT department. They have done the biopsy.
Yes,
and then
ma'am.
you got the reports.
Yes.
Right? Okay. So, what was the main suspicion while doing the clinical examination? It was the history.
Yes, ma'am. The history was totally going towards the infective cause. She had fever, she had right jaw pain, and she had history of teeth extractions. So initially we were also thinking about in terms of infection, and the places where she had consulted previously, they also were thinking about in terms of infection. So we investigated further.
Okay. So, imaging has been done after that.
After
only.
the biopsy, ma'am. When we found a globular mass, we got an
So, what were the DDs while seeing the globular mass?
Ma'am, in globular mass, first there is it was there in the sphenoid sinus. So skull and squamous cell carcinoma is the most common cancer of the skull base. So it like we were suspecting that, and we found that.
So, Charul, again, the sequence of the investigation is slightly confusing because if a patient presents with ophthalmoplegia, did she also have any sinus-related symptoms? You didn't
She
mention.
had a blocked nose, ma'am.
So, I mean, does that warrant a biopsy first or an imaging first? A total ophthalmoplegia with the facial palsy you are suspecting here. Of course, there's something going at the orbital apex or even beyond it because of the facial nerve involvement, right? So I would suspect something closer to the, the CP angle and other places, or even the ear somewhere, because both the things are involved. And that's a very, huge lesion because it's involving ophthalmoplegia also, which is total, and the pupils were also involved.
Yes, ma'am.
Pupils were also involved,
Yes.
and plus there is a seventh nerve which is there.
Yes.
Okay, so they are quite separated, not
Yes.
from the orbital
Yes,
apex
ma'am.
also. So big lesion. So I would first go with an imaging rather than going for an endoscopy.
Ma'am, actually here the attendant with the patient, his son-in-law was there, and he said that the patient underwent imaging, but they did not have any records. But they were told that there is some growth in the brain. So then we wanted to go for endoscopy first.
So all the more important to check the imaging first because any growth, I mean, you just don't jump into doing a biopsy because there could be something which is contraindication for a biopsy or something like that. Okay. So and you should be prepared for it. Like you want to go for a biopsy, you want to go for a culture, or sending for microbiology or histopathology guided by your own imaging. So I would go for an imaging first, or try to look at the films first, and then refer appropriately.
Okay.
Okay.
As you were giving history also, no, that they were telling there was some mass. So definitely, as Dr. Shailja said, first non-invasive should be there, then you go for the further invasive as per the reports, as per the localization. You cannot go like blindly for the
Okay.
this thing.
Thank you.
Thank you. So, is Sanjana is ready? No, not yet. Dr. Nandita is here, I think. Yeah. No, the last. This is the extra entry later video. Yeah, yeah, yeah. Okay, it's fine.
Good morning, everyone. I'm Dr. Nandita Trivedi, and the topic for my presentation is Unmasking Metastatic Lung Cancer Through Orbital Apex Syndrome. Financial disclosure, nil. Orbital apex syndrome is a rare ocular condition which has life-threatening complications. It can be either due to the mass effect on the structures traversing to the orbital apex or due to direct infiltration of these structures. Common etiologies include inflammation, infection, trauma, neoplasm, iatrogenic. Case details. Our patient was a 60-year-old female who presented with sudden onset painless diminution of vision and inward deviation of left eye since 1 week, and there was associated fever, headache, vomiting, tingling sensation over the left cheek, and pain in right lower limb which was radiating to the right hip. On general physical examination, multiple nodules on scalp and dorsum were seen, enlarged lymph nodes were observed, and there was decreased proprioception along the ophthalmic and the maxillary branch of the trigeminal nerve, and there was hyperreflexia in bilateral knee and ankle joints. On ocular examination, vision in the right eye was 20 by 30. In the left eye, it was hand movement close to face, PR inaccurate. RAPD was noted in the left eye. And on extraocular muscle evaluation, on Hirschberg test, there was 15-degree esotropia noted in the left eye and limitation of left eye extraocular movement in levoversion, levo-elevation, and levo-depression. And anterior segment and fundus evaluation were normal. Investigations were carried out. On blood investigation, increased ESR was noted, decreased TSH, T3, T4, FSH, LH was noted, and increased serum ACE was noted. CSF analysis was normal. On radiological investigations, on contrast enhanced MRI of brain on orbit, asymmetric hyperintense enhancing lesion of the cavernous sinus was noted, which was advancing towards the orbital apex, as we can see in the figure. On PET scan of the whole body, active soft tissue density lesions in the left lung with metastatic lesions in the brain, scalp, and the lymph nodes. And on HRCT chest, soft tissue hyperdensity in the left lower lobe was noted. FNAC of the nodules was done, and this showed mucin secreted adenocarcinoma, following which ultrasound guided biopsy was done, and this showed atypical cells in sheaths and nests with few signet ring cells, which was suggestive of adenocarcinoma, and tumor markers CA125 and CA were positive. We initially had differential diagnosis of systemic infection with CNS involvement. However, the CSF analysis was normal. We suspected sarcoidosis because serum ACE was increased. However, the HRCT tests were not suggestive of it. And idiopathic inflammatory disorder and thyroid eye disease were considered differentials. However, the radiological findings were not suggestive of it. And a provisional diagnosis of primary lung mucin secreting adenocarcinoma with systemic metastasis to the CNS, scalp, and orbit was made. The patient was referred to oncology department for further evaluation and radiotherapy was planned. However, the patient declined and she was kept on palliative care. Outcome, the patient succumbed to her illness secondary to septic shock and multi-organ failure within 1 month of presentation. We should have a high index of suspicion and for recognizing the prompt identification of the cause, and detailed and meticulous medical workup is essential with multidisciplinary team approach management. Take home message. Orbital apex syndrome due to orbital metastasis can be the primary presentation in case of lung cancer, and it is associated with grave etiologies that warrant a meticulous workup and a multidisciplinary team approach is needed. Thank you.
So wonderfully worked up case. So it was nicely worked up. Dr. Shailja, I skipped few slides, so you asked.
No, it was well presented. I think all of the cases, they are actually similar,
Same,
and
yes.
just underscoring the need for a good imaging in these cases, picking up the signs and going in for a good imaging. Most of the time, you may have to then refer them to subsequent specialities because it's not really under an ophthalmologist's armamentarium to treat all these, but picking it up is what lies, the onus lies with the ophthalmologist. So well presented.
Thank you. Ma'am, orbital apex syndrome is a rare condition, but here it seems like it's the most common occurring.
So I think yes, all the residents must have now come to know that orbital apex can present with varied presentations, and it is the workup which matters. The sequence, how you evaluate the patient, and then you can easily come to know what is the diagnosis. But if you mess up with the investigations, then it's difficult to come to the conclusion what it is.
Thank you. Thank you so much, ma'am.
Who is left now? Nishi has come back. Nishi? No. Ah.
Good morning. I'm Dr. Sanjana Thomas, and I'm here to talk to you about a 13-year-old female child who was diagnosed with TB meningitis on anti-TB therapy and presented to us with acute diminution of vision in both eyes. So, the diminution of vision in CNS TB can stem from tuberculous optic neuritis, posterior visual pathway involvement, paradoxical reaction to ATT, or ethambutol toxicity. We had to narrow it down, and we were left with two causes. Could the TB be affecting her visual pathway, or ethambutol, the drug that's supposed to save her, harming her? How do we decide on management without compromising her TB treatment or risking irreversible blindness? So she was started on ATT in April 2023 and was stable on it until June 2023 when she developed pain in left eye which increased with eye movements. The next day she developed blurring of vision in both eyes, more in the left side. She was taken to a local hospital and on the way she developed multiple episodes of seizures. Examination revealed an asymmetric vision loss, 612 in the right eye, 660 in the left eye, loss of color vision, sluggish pupil, and fundoscopy revealed nasal margin blurring in the left eye. Perimetry revealed incomplete temporal hemianopia in the right and generalized constriction of fields with foveal involvement in the left eye. MRI was a turning point which showed T2 hyperintensities in midbrain and pons, and contrast revealed left optic nerve enhancement along with temporoparietal leptomeningeal enhancement. So the diagnosis was clear, TB optic neuritis. But could ethambutol be a silent accomplice? We didn't want to gamble too much with vision, so we stopped ethambutol and levofloxacin was started for TB cover. She was also started on IV methylprednisolone pulse therapy. After 1 week, her vision improved to 6/6. After 6 months, she regained complete vision and color vision. She was found to tolerate levofloxacin well, and hence she was continued on levofloxacin. What is unique about my case is the atypical overlap of symptoms and the choice as to whether to stop ethambutol or not. So, was stopping ethambutol the right choice? Especially when it is the first-line drug of TB, and stopping it can risk treatment failure. On the other hand, ethambutol toxicity can lead to irreversible vision loss. Misdiagnosis can lead to unnecessary ethambutol cessation and delayed anti-inflammatory therapy. I would like to leave you with the following messages. Imaging is key. Ethambutol may not always be guilty, but if doubt persists, don't hesitate to stop it. When a patient is being started on ATT, always monitor vision very closely before starting ATT and while on it. Steroids can save sight, but only when inflammation is confirmed. So when a case like this presents to you, always think if it's a disease, the drug, or can it be both? Thank you.
Thank
So
you.
what is the basic protocol of eye evaluation while patient is on ethambutol?
Sorry,
So
ma'am?
how frequent? If patient is on ethambutol, what is the main protocol of following up those patients?
So we have to do a baseline evaluation and every 2 months. So we'll check the
So
vision.
there you have written, I think, 1 month
1 month.
evaluation. Yeah, so it's basically 2 months.
2 months.
So what you do on these 2 monthly visits?
So we have to do the basic vision, color vision, and better if we do an HFA perimetry, and OCT RNFL is like the best.
So it is in the protocol, or it's like your choice to do the perimetry or not?
It's in the protocol. If we suspect it, it has to be done.
Yes. Okay, nice presentation. Dr. Chandra.
So baseline, at least color vision and contrast you can do, and of course OCT can help. It can even detect, you know, early or pre-perimetric kind of an involvement. But of course availability is there. But basic, at least vision, color vision, and contrast, these three things should be done. Color vision is kind of affected the earliest, which is there. So again, interesting case. So what are the ways in which a tuberculosis can affect the optic nerve?
So it can have first optic neuritis. It can affect anything along the visual pathway, including chiasmatic lesion, retrochiasmatic lesion.
That is, you are saying the location. I'm telling you what mechanisms, what are the ways in which tuberculosis can affect the optic nerve.
Tuberculosis can be there.
Tuberculosis. So tuberculosis, what do they do? What will it do?
So that would be a neurosurgical approach.
So it will be a compressive. Okay. So one is inflammation, which you are saying direct invasion of the optic nerve due to inflammation or due to direct invasion. These are two different things. Okay. It could be a inflammatory, like a response to the tubercular antigen, which is like an antibody response, could be one thing. Then it could be direct invasion. It could be compression from the tuberculomas, and any other ways that it can affect. So as a result of raised intracranial pressure also, and the effect of treatment also.
Yes.
Okay, that is the ethambutol toxicity. Any other drug can cause toxicity apart from ethambutol? Any other anti-tubercular drug?
Isoniazid can also.
Very good. So even isoniazid can cause. Okay. So it is important to differentiate amongst all of these when you are having a patient in front of you who is a known TB, plus that's especially a cerebral TB, and then presenting to you with a visual loss. Okay. In your case, it was there was a sudden loss, there was a disc edema which was there. So goes more in favor of an inflammatory or a direct invasion. Although with ethambutol toxicity, also sometimes an optic neuritis kind of a picture is there. But the imaging is a very subtle imaging. There will not be like so the full length involvement, and that this actually shows a direct invasion or inflammatory kind of a thing where IVMP and continuing the medications would be there. Okay. Thank you. Any other person is present from the session?
Any resident is left from this session? Should I repeat the name, or no one is here?
She's there. What's her name?
Nishi. Yeah. Nishi.
So apart from Nishi, there are others. Shubhani, Shafra Shubhani, Nikita Sharma. You're there. Okay. Ishani, not there, and Samir. So I think only we have Nikita, right, after this.
Yeah, they are telling you. On this only, I think he's opening. Can we request Nikita to go first if her presentation is working? Yeah, Nikita, you can present.
You can proceed.
Yeah.
I need to tell them. Nikita, please play Nikita's presentation. Nikita.
Good morning, everyone. I'm presenting a case, third nerve palsy in case of pituitary macroadenoma. Introduction. The third cranial nerve or oculomotor nerve has two components, parasympathetic and somatic. Third nerve palsy has a variety of etiologies which may be due to different serious underlying pathologies like ischemia, tumors, trauma, hemorrhage, congenital and idiopathic causes. Patients presenting with pupil involvement are usually due to compressive causes, and pupil sparing cases are seen in cases of ischemic causes. My patient was a 35-year-old female with a history of drooping of left eyelid, and outward and downward deviation of left eye for 15 days, which was preceded by recurrent episodes of mild left-sided non-radiating headache, which lasted for 30 minutes. Her uncorrected visual acuity was 6.6 in right eye and 6.9 in left eye respectively. Best corrected visual acuity was plain 6.6 and 6.9 in the right eye and left eye. Pupillary reaction was normal in the right eye. The left eye pupil was fixed and dilated. Her anterior segment and fundus findings were within normal limit. On cranial nerve examination, all the cranial nerves were intact except for the left third cranial nerve. FDT and FGT were negative, that is, there was a paralysis of the left lateral rectus, and on FGT, no muscle power was felt. On PBRT, left exotropia of 30 present diopter with left hypotropia of 10 present diopter was seen for both near and distance. On word food dot test and diplopia charting, cross diplopia was observed. Her blood investigation was done, which was within normal limit, and RBS was also within normal range. Hormone profile was normal. For ptosis evaluation, her MRD1 in the right eye was 4 mm and minus 4 mm in the left eye. MRD2 was 7 mm in the right eye, and in the left eye it was 6 mm. Vertical fissure height was normal in right eye, and in left eye it was 0. Lid crease height was 7 and 8 mm in the right eye and left eye. LPS action was 17 mm in the right eye, and in the left eye it was not present. Bell's phenomenon was good in the right eye, and in the left eye it was poor. Corneal sensations were intact in the both eyes. These are the slit lamp images of the right eye and the left eye. On MRI, a well-defined lobulated homogeneously enhancing solid lesion involving cellar and supracellar region with extension into the left cavernous sinus was seen, which was pituitary macroadenoma. On perimetry, the left eye perimetry couldn't be done due to complete ptosis, and the right eye perimetry was near normal. There was nothing significant. On OCT findings, there was RNFL thinning in the left eye. Apart from that, everything was normal. My provisional diagnosis is pupil involving left oculomotor paralysis due to pituitary macroadenoma. She was operated for it, and a transnasal resection of pituitary adenoma was done on 10th April 24. These are in 9 gaze images in which we can see that the left eye is outward and downward deviated. These are the post of 9 gaze images of the picture in which there is no improvement. Isolated third cranial nerve palsy with pituitary macroadenoma is a very rare cases with few reported cases only, and the patient passed away after 1 week of the surgery while admitted in the ICU, which was possibly due to hyponatremia. Clinical implication: due to mass effect of the pituitary macroadenoma, there is compression of the left third cranial nerve causing ptosis, diplopia, and limitations of the ocular movements. And in my case, despite surgical intervention, the patient passed away. Take-home message: the underlying cause of third cranial nerve palsy should not be taken lightly and be investigated for any vascular causes like undiagnosed diabetes or compression from neoplasm. Earlier detection of the underlying etiology allows a better prognosis due to timely intervention and treatment, as it can sometimes turn deadly.
So, when you are evaluating third nerve palsy, what are the points in the history which indicates you to do the blood tests or investigations like MRI? What is your sequence, and what are the key points while evaluating when you decide which investigation to be done first?
Ma'am, this was an isolated case of third nerve palsy. Usually it occurs in association with other nerves adjacent. So we thought that it could be due to pituitary involvement. Like,
no, would you be seeing the history, the age?
Yes, ma'am.
So depending upon
patient's
that,
profile, ma'am.
And what are the risk factors associated in this patients? Accordingly, you will think of the DDs causing the third nerve, and then you will advise the investigations as per in that protocol. So that's what I was asking.
Yeah, so in continuation, you're saying this was an isolated third nerve, okay? So in isolated third nerve, when would you image and when would you not image?
Like we do imaging for all cases?
Not necessarily that you'll do imaging. That's what she's asking. So if it's an isolated complete palsy and pupil sparing in a patient who has a vascular risk factors, okay, like an elderly, diabetic, hypertensive, those could be pointing towards ischemic. There might be past history of ischemic nerve palsy which covered on its own. So these will tell you, okay, you can wait also. Ideally, yes, you should image because there is a 10% chance that these may also harbor some malignancies or some tumors or compressive causes, but that is where you can still wait and see for progression or betterment over the next few weeks, okay. But if it's a incomplete third nerve palsy or pupil involving, then definitely you have to image. If there is a less age, then you have to image. Any other allied signs like a proptosis, other cranial nerves. So along that line, again, one more question probably, how do you check for fourth nerve in the presence of a complete third nerve? How do you check for a superior oblique involvement?
Ma'am, we can, on the basis of extraocular movements, ma'am, we can see.
So how do you check for superior oblique in extraocular movement?
Like intorsion would be affected.
So how do you check? Clinically, how will you check? This is the third nerve palsy. Like normally where you check the superior oblique muscle? You ask the patient to adduct the eye and then depress, right?
Depress, yes, ma'am, forward.
So in third nerve, the patient won't be able to adduct only. So how will you check for a superior oblique? This patient might as well had a superior oblique also involvement. That's also in the cavernous sinus, right? So how do you check? You know that? So mention a little bit. So if the superior oblique is there, then while trying to adduct, depress during adduction with the eye adducted, there would be an intorsion. So that intorsion function would be intact. But at depression you won't be able to check because eye won't be able to adduct. Okay, so if you adduct and then you ask the patient to look down, although he won't be able to look, but in that process if the eye intorts, that means the fourth nerve is intact. Okay, thank you.
Thank you. So Ishani is ready.
We have the
Who
last.
was the next one?
Nishi. Just one more, right?
Nishi.
Then we wind up time on.
Yeah.
Okay.
So a very good morning to everyone present here. I am Dr. Nishi Satish. I'm a senior resident at Safdarjung Hospital. Today I'll be talking about a case of neurofibromatosis 2. So neurofibromatosis 2, we know it's autosomal dominant disorder characterized by the involvement of the Merlin gene on chromosome 22q. There is basically, the salient feature is that there are bilateral vestibular schwannomas in this, and the ocular involvement in this is either through schwannomas, meningiomas or ependymomas. We had a case of an 18-year-old male who came with us with the progressive painless loss of vision in his right eye first, and then later he developed proptosis in the same eye in a 5 years duration. The patient on examination, when we saw him on general physical examination, we saw that he had multiple subcutaneous nodules present all throughout his body, and he had a spinal deformity, he had scoliosis, and there was sensory neural hearing loss. On ocular examination, he denied the perception of light in the right eye, and there was abaxial proptosis of 5 mm and a vertical dystopia of 1 mm. The extraocular movements were limited in dextroversion and dextroelevation. And when we got an MRI for this patient done, we found that we did a CE MRI first because we wanted an integrated approach. There were two areas of interest here. Anteriorly, we found a contrast enhancing mass in the right orbit, which was involving the right optic nerve, extending up to the tip of the optic chiasma. And posteriorly, when we saw the same axial scan in CE MRI, we found that there was a contrast enhancing mass in both cerebellopontine angles, which was enlarging both bilateral internal acoustic meatus. So this was highly suspicious of bilateral vestibular schwannoma, and an integrated approach, like I said, had to be taken up. So in our case, we did an anterior orbitotomy and took a biopsy, and we found that it was actually a neurofibroma. Now, when we see a patient like this in neurofibromatosis 2 with primarily loss of vision, we suspected that he might be having a meningioma. But we found that there was actually a neurofibroma of the optic nerve. Now, neurofibroma, orbital neurofibromas can be seen in neurofibromatosis too. However, they are quite rare and they are mostly seen of the frontal nerve. So, finding a neurofibroma of the optic nerve in neurofibromatosis 2 was actually quite rare. So, this case is unique because the histopathological features were different, the presentation was very long-standing and different, and although genetic testing is not needed for the diagnosis of this patient, it is advisable so that he can get genetic counseling done later on. So with an integrated management, the patient had to undergo a gamma knife surgery to prevent the spread onto the other eye because the optic chiasma tip was involved. So with this, at least the other eye was able to be salvaged. These are my acknowledgements. Thank you.
Thank you. So when patient came to you, he was never been diagnosed ever?
Yes, ma'am. This patient presented to us. He lived in a village. He came to us after 6 years of not being able to see.
Okay. So those skin lesions, it was never diagnosed earlier?
No, ma'am. He came to us primarily in ophthalmology, and because we suspected neurofibromatosis, he could be diagnosed with other things like sensory neural hearing loss as well. Yes, sir. Like we said on general physical examination itself, we were suspicious that he is not able to reply as we would suspect a normal person to reply. And when we got an ENT consultation done, we found that there was sensory neural hearing loss. He was not aware. He was a neglected patient, sir. We have them in Safdarjung Hospital, sir. We get many.
Yeah, nice case, nothing much. I mean, I think you highlighted the importance of, again, doing a good examination and then subsequent investigations. Only thing about the genetic testing, and see, this is a very clear-cut case, and
Yes.
you really don't need a genetic diagnosis, and you don't always need a genetic diagnosis for a genetic counseling as well. Okay, he can still undergo, because conditions like these, Marfan's and all, you have criteria which will diagnose,
Diagnostic
you know, in
criteria,
the
yes,
absence of
ma'am.
genetic
Clinical
diagnosis and genetic testing, so that can still be done for him.
Okay, noted, ma'am. Thank you.
Thank you.
Thank you.
You can present now. You can add the names in the
Yeah.
paper.
So what's your good name? Athira. Okay. Gaudaman. Okay. Thank you. Athira.
Good morning, everyone. I am Dr. Adra Gaudaman, junior resident from Trivandrum. Small patients and big challenges. I'm talking about MOGAD. I'm talking about a patient who came with a child who came with chief complaints of sudden onset pain in the right eye, followed by defective vision of 1 week duration, associated with history of pain on eye movements. History of fever 2 weeks before the onset of eye symptoms. No history of recent immunization, no history of weakness, numbness, or headache, nausea, vomiting, and no history of seizures. On examination, in the right eye, visual acuity was 6/16, not improving with pinhole, and pupils grade to RAPD, color vision, red desaturation, and light brightness sensitivity was all abnormal, and the left eye was normal. Fundus, right eye, showed hyperemic edematic disc with blurred margins and peripapillary edema up to half this diameter area around the disc. And this is a right eye fundus picture, and left eye was normal. Neurology evaluation was done, and MRI brain and orbit contrast was taken, showing mild thickening of the intraorbital segment of the right optic nerve. Flash VP showed reduced P wave amplitude and delayed onset of P wave. Antibody profile showed anti-MOC IgG antibodies strongly positive, anti-aquaporin 4 IgG antibodies was negative, and ANA profile was also negative. She was started on injection prednisolone 30 mg per kg per day for 3 days, followed by oral Vizelon, and the patient was reviewed after 5 days. She was symptomatically better with visual acuity of 6/6 in the right eye. After 8 months, the child again presented with defective vision and pain in the left eye since 1 day duration. On examination, right eye was found to be normal and the left eye visual acuity was 6/24, not improving with pinhole, and grade 3 RIPD. Color vision defective, red desaturation was positive, and light brightness sensitivity was decreased. And fundus, right eye appeared normal and left eye was the fundus was hyperemic edematous disc with blurred margins and peripapillary edema up to half disc diameter area around the disc. And this is a right eye fundus picture. This is the left eye. OCT optic nerve had showed left eye peripapillary RNFL thickening increased in the inferonasal, temporal and inferior quadrants. MRI brain and orbit contrast was taken showing thickening of the intraorbital segment of the left optic nerve. And the diagnosis of MOGAD associated optic neuritis was made. Discussion. Myelin oligodendrocyte glycoprotein antibody associated disease is an inflammatory disorder of the CNS characterized by immune mediated demyelination targeting the optic nerves, brain and spinal cord, and it is common less than 18 years of age, and the male is to female ratio is 1:1. Incidence of MOGAD is higher in children than in adults. Incidence is 3.1 per 1 million, and in pediatric populations it accounts for nearly 50% of acute demyelinating syndromes. Acute disseminated encephalomyelitis or the ADEM is the most common of all presenting cases of pediatric MOGAD, and optic neuritis is the second most common manifestation after ADEM. The annual incidence of MOGAD related optic neuritis is approximately 1.6 to 4.8 per million people. Optic neuritis is mostly bilateral, but simultaneous bilateral optic neuritis occurs in 31 to 84% of all MOGAD cases, and approximately 67% of the IgG positive patients experience more than one optic neuritis attack during the follow-up. And disease courses in children is milder compared to adults, and it is more likely to experience complete recovery, and challenges can be early diagnosis and treatment and variable presentation leading to misdiagnosis. Predicting the course of disease and managing long-term complications can be challenging for the physician. Thank you.
So clinically, if you have to differentiate MOGAD from optic neuritis in, let's say, a child or an adult, what would be the clinical features that you would look for specifically, or even the radiological features?
So we can see in the, in the MRI we can see, sir, the long segment will be involved. Mostly in multiple sclerosis, short segments along with the long segments will be involved. In case of aquaporin 4, only the long segments will be fully involved.
Yes, and any other places in the brain or any other things that get involved?
So the periventricular areas will be involved, sir.
In what?
In case of
so how is the periventricular involvement of MS different from what you would get in MOG or MOGAD disease? So those typically described dorsums, fingers and periventricular, juxtaventricular would be there in the MS, but they tend to be a little more spaced out and further away in the MOGAD disease. As also involvement of the chiasma is more common in MOG. You tend to get that involvement as well. So these are some features, and clinically of course it behaves slightly differently, and it has a higher chance of recurrence, and the outcomes are poorer compared to what typical optic neuritis would have.
And even the presentation, how the patient present with how much vision loss.
Yes.
That is also differentiating. So you do these tests in all the patients of neuritis comes to you, or is there any indication of doing which test in which patient?
Ma'am, in pediatric patients, mostly it is MOGAD is one of the differentials because it is very unlikely to be multiple sclerosis or
So you do it in all the pediatric patients?
Mostly we, along with MRI, we opt for a MOG antibody and ANA profile. Along with that, we sent all these together. So that is one of the...
So pediatric optic neuritis, if you look at the as a whole, then you've got seronegative and seropositive. Within seropositive, MOG is more commoner than NMO, right? Almost about 29% would be MOG as against about 7% NMO. And then there's ADEM, which is basically the bigger group, which again comes into seronegative, but would present very much sometimes like optic neuritis to begin with. So it's it's something that we're getting more frequently now that we are testing. But as Dr. Anita was pointing out, you don't need to do all tests and all. It's only indicated where you're specifically finding one kind of a clinical presentation or a radiological presentation.
Thank you, sir.
Thank you.
Thank you.
Swati, we can have the speakers for a photograph, group photograph in front in the meanwhile.